Hi, so I'm Dr. Rajneesh Kapoor. With me, Dr. Himanshu Debral, Dr. Manish, and Dr. Hardeep. They are on the transesophageal echo imaging. So we are recording this case for this India valve, and I'll give you the introduction. Now, this patient is a 79-year-old. He had acute coronary syndrome somewhere almost a month back. So he complicated by heart failure, so he was admitted at some other hospital where angioplasty was done, and at that time his ejection fraction has been around 30-35%, but constantly even after the angioplasty he continued to be in advanced heart failure, not responding to diuretics. He was constantly requiring BiPAPs, CPAPs. He was on inotropes and intra-aortic balloon pump too. But all this 1 month, he was practically, he has been in heart failure and desaturating all the time. And then that also led to progressive renal dysfunction. His creatinines went up to 3.4, 3.5. So with this, he came to us about 10-15 days back. We have been trying to stabilize with all the possible measures, but still nothing major worked out. He still desaturates at times. He requires high flow oxygens. Now only thing which has happened in last few days that he's off inotropes. He's passing good amount of urine. His creatinines has come down little bit, 2.2 now. So now with this history, we were trying to define that what's the cause, that why he's not coming out. So along with LV dysfunction, this further complicated that he had a severe mitral regurgitation. Florid MR, that was the reason that he had a refractory heart failure. And then after a long discussion with the family, we thought and we planned that if we can do a clip to mitigate this MR, we can actually treat or make him better from the heart failure point of view and to salvage this patient.
So I will now show the echo images of this patient. Yeah, so as we can see here, he has got tenting of the PML here, because of which AML is completely overriding PML, resulting in pseudo prolapse of AML, and that is leading to very significant MR. So he's got torrential MR almost posteriorly directed because of pseudo prolapse of AML. And we've taken some 3D images also. So here are his 3D on fast view images. So as we can see here, AML is completely bulging towards the LA because of the pseudo prolapse. This is a different projection of the same, and as we can see here, there is a broad jet of severe MR. The other important point in this patient is the septum. Now unfortunately this patient seems to be having quite thick septum, as we can see here. So entire septum is thick, there does not appear to be any thin part.
So these are the two challenges which we are going to face. Perhaps one, the thick challenge, thick septum, and the second, probably grasping will be little tough because of the pseudo prolapse, as Dr. Manish has just.
So we can check the height here.
Yeah, looks okay. Height is good.
Looks very good actually.
Yeah.
4.5.
Okay.
This should be okay.
So we'll take it, huh?
Yeah.
Okay. So it looks stable. So we are going with the septal puncture here, and we are now giving a cautery. Okay. Yeah. We can see something in LA, but still some tenting is there. That's because of the thick septum.
Not completely through.
Yeah. Okay. Needle is in, so I'm now pushing the sheath over it. I think I'm there with the sheath. Why the tenting is maintained? Sheath is inside now, and tenting is now gone down.
Yes.
Okay. heparin 5000. Okay.
So this is where the puncture has happened. 4.7 centimeters.
So it's a very good height in the mid portion and quite posterior, looks good. Look at the MR. So it's a very, torrential MR. After puncture, we get this spiral wire in, which we use in our BMV, and over that we get a SL sheath in LA. Yeah, just check LA. So now we'll introduce a Safari in LA, and over that we'll have a Abbott sheath. Okay, so this is a Safari wire in LA. There are certain people, certain operators who would use Platzer stiff, but we find Safari to be more safer and more convenient to get a sheath in. Now this is a 25 French sheath, and one should be careful while negotiating at the groin and gently push it through the vein. So now we are in and we are heading towards RA. So once here, the important step is to give a minus here so that it is directed towards now LA. Okay, so it should be free here, and that's what I have done. So now it is directed towards LA. So now this is again a very crucial step, that we should be very careful while we advance this sheath across the interatrial septum, and it should be properly under vision by transesophageal. So, but be careful, this is a very important step, and any rash movement actually, it's anterior, so go posterior. Okay, is it fine now? I'll check and synchronize with Dr. Manish. We are all set for the next step. The sheath is in place, and now the clip delivery system. We're taking XTW, that's what our plan is. It's a torrential MR. The vena contracta also looks quite wide, so okay. No problem. Okay. So we are advancing the clip delivery system. There are a few steps here which are important to take care. It should be that there are markers on the sheath and the clip delivery system that has to synchronize with each other. And once this is done, we are there. Okay. We reach the tip of the sheath.
Yeah, so the clip has.
Yes. So now we are almost touching the LA wall.
Yeah.
And so some M is required. We need to tilt it with more with the rotation on the M knob. Okay. Yeah. Another thing is, since we have some length of the sheath in LA, we can retract a little the whole system little back, so that we have more space.
Yes. Yeah, we can do that.
Yeah, I am taking the whole system back, being very watchful that how much length is there in LA. So this is important. We have to be in the cavity for further advancement. It should not be directed towards a ridge or the LA wall. So that's where we'll have inputs from Manish regarding the trajectory, and then correct it, and then check the clip arm position.
Although we are almost vertical, but we are too posterior and lateral.
Okay, so we are correcting this, coming more anterior.
And yeah, we will have to withdraw the system and give
so
little bit
M
also
to come little medial. Look, so yeah, we have come medial, and it looks much better. Slight more. Where is aorta? Aorta is on the top.
Yeah.
Okay.
Top. Yeah.
So then posterior. It's more anterior.
And now it's more anterior.
Yeah.
Yeah. It's okay at present.
Now it's okay. It's directly above the coaptation line. And we check in the bicom as well as LVOT views. Trajectory, it's looking a mild aorta hugger here.
Yeah.
So we will correct, and this is what is required. The solution is we'll give some plus here. So I'm giving plus on the knob, and after giving plus, and then come more anterior, Okay.
Yes.
So this is now better.
Yes.
So
Yeah.
let's check the clip arms. So we are opening the clip arms. Windows हम तो देख ही रहे हैं यार,
It's
तभी तो काम कर रहे हैं.
rotated.
Rotated. Yeah. Okay. So the orientation of clip arms is not appropriate. It seems to be quite rotated. And now we'll do the correction step here. So look at this. So this is almost at 10 o'clock position. We have to rotate it clockwise. So this seems to be the good position, and it has to be checked in LVOT view and in fluoro also. So good point is, see, look at fluoro. There is no parallax between the clip arms. So now this is also important. While we advance, it should maintain this position. If it doesn't, then that means a rotation has happened and we'll reorient the clip arms. So we'll close the clip arms, advance, and then once we are in below the mitral leaflets, we'll open it again and see the orientation. We close the clip arms. It looks okay. Hai?
Yeah, looking better.
Okay. Let's see now whether we are
Yes.
okay. Yeah, looking good.
Yeah.
Even posterior seems to be sitting there. Okay, slightly open. Have come more medial.
Yeah.
Now
yes,
looks
now it's dropping.
now looks good.
Yeah, now it's dropping.
Okay. Okay. Anterior gripper. हाँ.
ठीक है, MR भी देख लेते हैं एक बार.
Not sure. है ना? SLD हो सकता है. MR तो बहुत अच्छा हो गया. AML पर कंफर्म होना चाहिए. That's okay. Okay, बस stop. ओरिएंटेशन ठीक है ये.
ओरिएंटेशन तो ठीक है.
सिल्वर आएगा.
सिल्वर आएगा.
सिल्वर पीछे सिल्वर रिंग आएगा बाहर. हाँ.